Welcome to this episode of Orthodontics in Interview. Now, it's my absolute pleasure to bring you the man of the moment in aligners, Dr. Vincenzo D'Antò. Thank you so much for joining me for this interview in Orthodontics in Interview.
Thank you. Thank you for the invitation.
This year has been an amazing year for Dr. Vincenzo, and he's published 2 consensus statements on aligners, and I'm so grateful for him to give his time to come and talk us through the consensus statements and really looking also at his clinical practice. I really enjoyed our conversations, and I'm really excited to bring him to you guys to kind of start to bridge this gap between academia and clinical practice. Where do aligners actually fit in terms of both aspects? And there's nobody better to guide us through that than Vincenzo D'Antò. So let me tell you a bit about him. So he is the Associate Professor in Orthodontics at the University of Naples, Federico. He graduated from the same university in 2006. And this is where things just go mad. So he did a PhD in material and structural engineering outside of orthodontics. Then he did a specialty in orthodontics in 2012. He then did a second PhD, I kid you not, in oral sciences in 2016. And then he specialized into pediatric dentistry in 2025 this year. What a journey. He's also done additional training in TMJ, lingual orthodontics, and sleep dentistry. He's also had other commitments in terms of academia. So he's co-authored over 120 scientific papers, including a textbook. In terms of research, he's been involved in national and international research projects, including with Align Technology, one on Class 2, one looking at cuspids as well. His commitment to academia is also in terms of our editorial roles. He's an associate editor of 3 journals in orthodontics: Progress, Orthodontics and Craniofacial Research, and the illustrious American Journal of Orthodontics and Dentofacial Orthopedics, as well as editorial roles outside of orthodontics for 2 other journals. Supervisors PhDs. Awards are numerous. But of the largest awards that he's received are the incredible Euston Award from the European Society. He's received the IADR Frank Roberts Award and the FEO Best Article in 2025. He also has humanitarian commitments in terms of projects carried out in Ethiopia since 2013 with HEWO. Fantastic, and it's great to see that you are involved in so many things, especially helping people at large. Vincenzo, thank you so much. There's probably a whole podcast just on your CV, which we're not going to go into, but it's incredible just to look into what you've achieved so far. And what I want to get into to begin with is the consensus statement that you published earlier this year in the summer, which is a Delphi study looking at the indications and limits of clear aligner therapy. And that was published in Progress of Orthodontics. I want to know what led you to make such a novel statement in clear aligners in orthodontics. How did you get to that paper?
So this was an idea of Italian Orthodontic Society president Lorenzo Franchi. He is the president for 2025, and for the spring meeting and the main meeting of the society, he decided to prepare a scientific material through a paper and through a consensus conference. So there were 2 consensus published, one about Skeletal Anchorage, it was in March, and this about aligners, because in 2 weeks we are going to celebrate our annual conference, and we will have one day session about aligners. So the idea was from Lorenzo, but I accepted it, very well, because I think it was needed. And it was needed to have a simple and clear paper to be read not only by orthodontists, because in my opinion, orthodontists should be already aware of most of the statements that we have written, but it is mostly for general dentists, so for all the dental community, and also for patients. So this was the main idea. And of course, we were not setting the limits, so what an orthodontist can do, but we were trying to explain what is more suitable to be done with aligners. So what are the best indications and what might be, the best advantages of using aligners. So we didn't want to limit the field, but we want to give information to who is not really into it.
Very interesting. And in terms of your panel, so you had your 23 panel members. How did you choose who's an expert for the state?
So Lorenzo created the method, so the protocol, and in the protocol it was required to have a panel with members both from the academics, so with an academic background and a clinical background, and covering also different geographical areas. So we have selected panelists that are from all continents, and most of them are involved either in university or in clinical practice, running large aligner practices. And of course, for the clinicians, it was very important to have those involved in the scientific societies. Maybe you know that there are many aligner societies nowadays, the European Aligner Society and many regional societies. So, for example, we had Stephen Chang, that is the past president of the Taiwanese Aligner Society, or John Kaku from Japan, or people from the US, Brazil. We were covering the entire globe. I think this is one of the main difference with, for example, the other consensus where I took part, that has like 19 Italian panelists out of 30. That I think it is not really a good geographical representation.
Yeah, and that was going to be the next thing I was going to mention. As a keen reader of Kevin O'Brien's blog, he also mentioned the second consensus statement, also from Italy, by Nicky Arveda from Ferrara in November. And these two consensus statements also had, relatively speaking, only a few experts between the two of them, which were the same. Tommaso Casafiore, Björn Ludwig, and George. And it states that yours was more looking internationally, whereas perhaps the second statement was perhaps more localized to the Italian academics and experts. I'm going to ask you about key opinion leaders. So Kevin O'Brien made a mention of this, but in terms of deriving your experts, did people have conflicts of interest? And if they did, what do you think about that? Does that not perhaps warp what they may have stated in terms of your consensus?
I think it is very difficult to find a real expert in the aligner treatment that do not have any conflict of interest. In general, I would say that is almost impossible, because even when you get a discount from the company, this is a conflict of interest. And if you are treating patients with aligners, for sure you get a discount. But then if you are an expert, of course, you are lecturing, and very often these lectures are in company meetings. So I would say that to set the threshold of the conflict of interest is not easy, but in general, I would say if we set the higher threshold, it is extremely difficult, especially among clinicians, to find possible panelists without a conflict of interest. So I would say that in both articles, there were many authors which had some sort of conflict of interest.
And do you think that changed the results? Do you think that influenced things?
I don't think that it changed the results, because in the end, what it can really change the result is the way you are writing the statements. Okay, so in just to go a little bit inside the methodology of a Delphi consensus, the steering committee has the most important role, because it is writing the statements. So this is already a way of orienting where you are going, because then, of course, they could not be accepted, and this happened. But you might not write a specific statement, like the one that you don't believe are correct. So the panelists, they are more involved in the process of rating. So saying, okay, I agree or I do not agree, and why I do not agree. So what I would like to change in the statement. That's the way. So I think the steering committee is really the most important body of the consensus people. But then, yes, there might be some influence of your background and also of your conflict of interest. But surprisingly, I think that even if the panelists of our consensus were huge aligner users, the statements are not so in favor of aligners. I would say that they are really reasonable.
Yeah, and I think it's probably getting to that point, isn't it, where working with industry is an incumbent part of some of these aspects within clinical practice and research. And perhaps we should just set the expectations around our fellow qualified specialists and clinicians that we expect higher in terms of their ethics and morality as we are delving forwards into perhaps a greater combination with working with industry.
May I tell you, my rule regarding key opinion leader was inspired by Kevin O'Brien, and actually one key opinion leader that is Jason Cope. And basically, the idea was that every time a key opinion leader is telling something that sounds not reasonable, you can ask, to prove it. Okay. So if you are telling something that it is not in the literature or it is not reasonable, you are entitled to be asked for the proof, and you are the one that has to provide the proof. Okay. So if I tell that it is possible to make a skeletal palatal expansion at the age of 90 years old, okay, then everybody from the auditorium can ask me what is the evidence, okay.
That's very good. So the proof of burden of evidence lies upon the person of the statement, whether they have a conflict or perhaps even if they don't, right? Somebody presents an idea, a concept, the burden of proof lies. And I think that's a great expectation for us to have as orthodontists in our community. And therefore we can accept people from different aspects of influence. Vincenzo, diving into your consensus statements. In terms of crowding, you found clear aligner therapy to be an alternative to fixed appliances for class 1 mild to moderate cases. And I think that is as an idea is well established now in terms of orthodontic clinical practice. What I want to get into is a recent study in October by Ziad Alharfi in the EJO, which did a systematic review looking at fixed appliances versus aligners. And they found a slightly different outcome in the research. They found that the outcomes with clear aligners for mild to moderate cases was better than fixed appliances. And they used the ABO as far as their outcome tool, and it was 6, which was the difference, 6.23. Now, in terms of the ABO, just to put into context, 20, the higher the number, the worse it is. You get to 20 and it's a pass, you get over 30 and it's a fail. So 6 is quite a reasonable number in terms of the advantage of clear aligners relative to fixed appliances. So how do we understand this new piece of research, systematic review, compared to your consensus statement, which shows that they're equal?
The problem with systematic reviews is that their results are never better than the primary studies that you are including. So the main problem is the primary studies that we have. Many of them are retrospective studies. So in retrospective studies, you have the tendency to overestimate, how good is your intervention. Basically, you might have lost failures. And I would say that we have 1 point in favor of aligners and 1 point in favor of fixed appliance. So the point in favor of aligners is that for this typology of cases, you keep much better the anchorage. So if you do not use a very advanced biomechanics and you just use straight wire appliances, you know that it is very easy to lose the class relationship during the treatment. So you start with a very nice class 1 relationship, but if you don't take care, you might be in class 2 after a couple of months, So a good orthodontist is avoiding it, but it is still happening. While with aligners, yes, of course, you still have counter forces, but you can play with your staging and with your setup in a way that is helping you in maintaining the anchorage. On the other end, you have a compliance issue with aligners. So I would say that you will never have 100% of success because you do not have 100% of compliance. So it is like if you take retrospectively the cases, most probably you will find this difference in favor of aligners. And this is not new. The first systematic review that was showing that is from Bushang, and It has more than 10 years now, and it was showing a difference of 6 months. But on the other hand, I think that we should be reasonable, and I would not say that one appliance is better than the other, but depends on the patient, on the compliance, and that's why our statement was affirming that they are equally effective and equally efficient. But I see some very good points in favor of aligners, and one is the Anchorage management.
That's really interesting. And it sounds as though you've been seeing some of my fixed appliance results in what you've just described in terms of losing Anchorage, but we won't go into that. This is your interview. Thank you very much for clarifying that. That gives us a really good summary of what your consensus statement found. I want to give the audience something to in terms of the clinical practice. And one of the debates that always take place is, do you give your patient aligners for 7 days? Do you give it for 14 days? Manufacturers have a variety of different protocols for them. Now, I would say somewhat disappointingly, in your consensus statement, it stated that staging between 7 and 14 days was advised by the panel. So it didn't really gun down to giving us the answer. Is it 7, 10, or 14? In terms of how we interpret your consensus statement and what you do in clinical practice, which is it? Are you choosing 7, 10, or 14? And then how do you apply the evidence that you've created?
Okay. The point is that we are not defining which material and which aligners we are using, and which staging, so which amount of movement for each aligner. So these are all the important factors. And then the important factors are the age of the patient and the type of movement that you are planning. So it is exactly like in fixed appliances. I will not tell you if you are maintaining O14 round wire for 2 months, 3 months, or 4 months, because it is depending on the patient. So my rule is quite simple. First of all, you have to assess the compliance of the patient. Okay. So even in simple cases, the patient might be using aligners not full time, and you have to assess it. You have to ask cooperation from patient, and they should not lie. Okay. So if they tell you they are not able to wear 22 hours, for example, this might be a reason why you are changing every 14 days. Okay. So let's say the idealistic condition. The idealistic condition is a growing patient or a young adult with predictable movements. I will change every 7 days. And if I have a plan that is a difficult one, for example, a class 2 correction, okay, with 40 or 50 aligners or things like that, I will tell in advance to the patient that for this type of treatment, it is required perfect compliance, because we want to change aligners every 7 days. And this will allow us to make the treatment in a reasonable treatment time, because we will have the first year for the first 50 aligners and then some refinements. So this is also something you have to communicate with to the patient. And also you have to communicate that changing aligners should be done only when the fitting is perfect, and they know how they have used these aligners. So they know if they are not using enough hours, they should not change every 7 days, but it is better to do every 10 or 14. So my rule is that I am changing every 7 days in growing patients, in young adults, when I have a huge number of aligners. Or if I have like 20 aligners, very often I change every 10 days, because I think this is the good compromise. For perio patient and older patient, I would say more than 35, 40 years old, I prefer to change very often every 14 days. Okay. And it is also changing the speed of the movement. There are two conditions where we change the speed of the movement: perio patients and Braxers. In these patients, we slow down the speed, but in Braxers, we change every 7 days, while in perio patient, we change every 14 days. So sounds a bit complex, but I can make a table for you. And if you take a look to the table, it is quite simple. But it is very important that you understand this is not cookbook orthodontics. You have to adapt to every specific patient and also to monitor the compliance of the patient. That's the point.
Really good. I look forward to seeing that table and sharing that with the audience. Thank you very much for that. Now, in terms of complex movements, I'm just going to make a quotation from the paper and really to understand what the state of play is of aligner biomechanics at this stage. So, complex movements increases the likelihood of additional refinements, likelihood of switching to conventional fixed appliances, auxiliaries, refinements, or overcorrection, often required because aligners fail to fully correct premolar and canine angulation, inclination, and rotation. There's a 91% agreement to this statement. So the panel very much agreed to these limitations. Do you, Vincenzo, see this as a design flaw within clear aligners and an inherent limitation as to their mechanics?
Make a question. The question is why we are still relevant as a profession. We had a very good friend, professor from Athens, George Kanavakis, in our university last Monday. And his answer was, we are still relevant because we change the face sometimes and in general the smile of our patients. So maybe it is not always required to rotate the premolars or even to correct the crossbite in an adult patient, of course. So I would say that you must understand very well what you are using, and you must inform the patients. And maybe the patient, the specific patient, he just is asking for an aesthetic treatment or a cosmetic treatment. Of course, I don't like at all to compromise in growing patients and in young adults, so I would not do it. But I don't see it as a flaw. I have some patients that will never accept any other kind of appliance. They would rather refuse the orthodontic treatment, okay? And maybe they are not interested in correcting the skeletal class 2 malocclusion with orthodontic surgery, but just the rotation of a lateral incisor. That's what we have done. And I think this is very reasonable. I am a surgical patient. I have a class 3 and a posterior crossbite, and I would never do surgery for myself. I'm totally fine with it.
Fantastic. That's so insightful. I just want to push you a little bit more in terms of the limitations for aligners. How do you explain those limitations? What does it come down to you as an academic and clinician to explain why aligners are limited in the descriptions that you've given in your statement?
Yeah, I think the main problem is the material. Okay, so as I am a material scientist, polymers are completely different from alloys. Completely different. Okay, so this is giving you the background of the limitation. And then, of course, compliance is an issue. But let's assume that we are in an ideal condition with perfect compliance. You still have the issue with the material. Okay, so there has been an improvement in materials. Not really in the 20s. It was mostly in the previous decades. So we have not had many improvements in the last years about um, polymers used for aligners. If you do not consider, of course, 3D direct printing, but 3D direct printing is another story. Yes, it is the real breakthrough, but at the moment there's really many shortcomings, many problems, to be used extensively. So I don't consider still like the um, standard technology. So I think this is the main answer. It is very difficult to move the root apex to make a bodily movement because it is very difficult to deliver a moment, and this is related to the type of material that we are using. And it is very clear for an orthodontist to understand what we are talking about.
Thank you. I mean, this is fantastic because this is really helping to translate all the information that you've gathered from your research and papers and just pinning it down to one or two statements.
I want to tell you something about the statement. The statement is also intending to say to general practitioners that sometimes use aligners, you should not promise to your patients that the project will be, in the reality after the first set of aligners. And if you are planning unpredictable movements, you have to explain very clearly to the patients that the number of aligners is completely different because you might have many refinements. So the efficiency of the appliance is not very high. And because sometimes they don't do it, and the patients are really complaining because they were very good in compliance, and they ask, why do I need the refinement now? I was wearing 22 hours, I was doing what you told me. So I think it is very important to give the correct communication that, yes, if you are doing an unpredictable plan, means a never-ending story, and maybe you will never get the result.
Excellent. Great to see the intent behind the process and where you see it really being applied. I want to go into the next stage of the interview, really, which is to get down to one of your aspects of clinical practice, which are hybrid orthodontics, aligners combined with additional auxiliaries. So it probably springs out from your statement as well that 80% of the expert panel were using hybrid mechanics in almost 40% of their cases. So quite a considerable amount. And hybridization looks as though it's solving that problem that you've just described very eloquently about the limitations in terms of the materials. And perhaps we hit the biomechanical ceiling with the limitations of the material as they stand. So, my question to you is are hybrid mechanics or the hybridization of aligners the next stage for us to get that predictability? Is that now what our focus should be around in terms of using this appliance for more complex movements?
But I think that for the orthodontist, this is obvious, okay? Because if you are an orthodontist, you are used to include different type of appliances in a comprehensive treatment plan. Okay, so I think for an orthodontist, it is really, well, we are out from the paradigm that we use aligners to have only aligners. Okay, nowadays we use aligners to do an orthodontic treatment, and most of the patients accept, the integration with other procedures or other appliances. So I think it is really something that it is almost obvious. The problem is if you are not an orthodontist, are you able to use other appliances? Are you able to integrate them into aligners? And then, the question mark, I think it is a little bit a rhetoric question because you might learn how to do it, but of course it is more difficult for you. So you have to study a lot if you don't have the background to integrate other. But yes, I see that if we have a complex treatment, this is of course the option. I would like to say what is my opinion. My opinion is that we are too much focused on the millimeters and the degree. So I call it the micro predictability. So how many millimeter I can intrude, how many degree I can rotate, and people they really want the cookbook. Okay. So when I do my project, how many degree, how many millimeter, I think this is pure stupidity. I think it is much more important to focus on the macro predictability of the case. So the diagnosis is very important. And sometimes you use an hybrid treatment or an integrated treatment because you have biological limitation. So it is not only because of the biomechanical limitations. If you do a MARPI with aligners or a MASPI, because we do it slow, but depends how you want to do it, you will do a MARPI also with the fixed appliance, most probably, okay, because there is a biological limitation, not a mechanical limitation related to aligners. Of course, if you use a palatal expander, tooth-borne palatal expander in a growing patient, you would use before fixed appliance or before aligners. So I think it is not the limitation of the. Then yeah, if the problem is the rotation of a premolar, you can use a power chain or a segment of braces. Come on, this is very simple for an orthodontist.
And in terms of your favorite hybrid mechanics, what tends to be common for you to use in terms of those auxiliaries in practice?
Mostly sectionals, but the most common case is with mini screws. So to manage the anchorage with mini screws, and very often cantilevers on a mini screw, or a mini screw used for indirect anchorage, or appliances on mini screw like palatal expander and distalizers or mesial slide. I'm very good friend of Benedict Wilmes, and I think he has done a lot in this field, also trying to do protocols that could be used by other clinicians. So I think that incorporation of skeletal anchorage, maybe it is the most common, but also using sectionals or power chain. Very often I use power arms, but I don't even consider them hybrid. For me, it's just an auxiliary. It's like the attachment and the elastics. So then in terms of integrated treatment, I am still using orthopedic appliances like twin block. Actually, I use the bijambic appliance from Professor Sander, but it is similar concept. So if I have a skeletal class 2 with the mandibular refusion, I still like to use them before aligners. Or of course, we integrate orthodontic surgery and other procedures when they are needed. But this will be the same with braces. So I don't see difference in this regard.
I love that idea that actually you've got aligners, attachments, and you have auxiliaries. That's all part of the same thing, and the mini screws seem to be your go-to tool, and power arms are just part of aligners. That's really interesting. It's kind of making aligners look larger as far as the armamentarium to clinically practice with them. And congratulations, by the way, on your paper from yesterday in Seminars in Orthodontics, which will come out in a few weeks' time after this podcast, looking at skeletal expansion with aligners, showing that you're integrating, as you've described very eloquently, the idea of biological limitations, resolving them, and then using an additional appliance then to complete the case. So congratulations. What a year it's been. What a year. I wanted to ask you about extraction cases. And this is a point where there's a bit of a divergence between experts who are using clear aligners as well, in terms of whether they do, whether they don't. Now, in your consensus statement, it was found that the majority of the panel, 78%, agreed that you get poorer occlusal outcomes, reduced incisal torque, greater tipping taking place of the posterior teeth, and mentioning how fixed appliances were superior. Now, my question to you as a clinician as well is, do you carry out extractions with clear aligners? And if so, how do you resolve this discrepancy that your panels stated?
You have different type of extraction cases. Do you agree with me? So, for example, with fixed appliances, for me, it is much easier to manage an extraction case where the reason for the extraction is a huge crowding than an extraction case where the reason is no crowding but big protrusion. Okay, because the anchorage is completely different, the anchorage management, and also when you have crowding, the space is almost closed after you have aligned. Okay, so not all extraction cases are the same. So we should speak about, in my opinion, the type of movement. So of course, if you need a bodily movement, this is a difficult movement with aligners, and also age of patient, because it is completely different in a growing patient and in an adult patient. So once again, I'm sorry to say that depends on the patient. For example, I have published a class 3 subdivision treated with premolar extraction with the 44 extraction. And in that patient, the cuspid, the 43, had very positive angulation. So the root was already in a good position. So why not to do the extraction to correct the cuspid class and the midline? So what I do is, if I do an extraction case, I inform the patient that root movement might not be achieved fully, and a final course with the fixed appliance, so a final phase with fixed appliance might be needed to refine, to have the perfect occlusion. Or if I start already with unfavorable position of roots, I prefer to incorporate sectionals of partial fixed appliance from beginning, or even to start before with a different mechanics and then do the finishing phase with aligners. So even the timing of the use of the hybrid treatment can change. It can be in two phases, in one phase, first aligners, aligner after. Depends. You have to customize on your own case. So I'm treating extraction cases, not too many, because when you explain the difference to the patient, then most of my patients choose for the fixed. So because I explain very well the difference. I'm not selling aligners. The problem is when you are selling aligners, okay, because unfortunately some colleagues, they are a bit, let's say, pushed by the companies to sell aligners to make a certain number, to reach a status like a tier, like I am the diamond or I am the, I don't know what. And this is really a bias in your communication with patient. But if you are telling pros and cons of appliances, then some patients will not choose aligners maybe.
Really good to get your insight into that and to perhaps some of the things that sway us in terms of clinical practice, and where you stand, which is also really important for us to know, considering your commitment to the literature. Oral health, quality of life is something that you touched on, and I think it's great. And this is something that Kevin O'Brien's very much been a bastion of in terms of looking at things just beyond the occlusal outcomes for our patients. And in your consensus statement, you very much asked this question. And the outcomes that you found was that patients had a better oral health quality of life compared to fixed appliances. They had less pains during treatment as well. And my question to you is, with all the limitations you've just described in terms of aligners and why they take place, is it worth having poorer outcomes in terms of our occlusal outcomes if the patient has an elevated oral health quality of life? How do you draw those two ideas together?
No, in my opinion, it is not worth. And I want to tell you that actually the literature is not really showing that you have a better oral quality of life with aligners. So this was more the opinion of the expert, because many papers just show there is not a big difference. Maybe during the treatment, of course, not after the treatment. But, for example, we have experience with special need patients, syndromic patients. There is a colleague in Milan, she's fantastic. Costanza Mazzini, she's treating a lot of syndromic patients and cleft patients with aligners. And for this patient, for some of them that have already a huge burden of care, it is really making the difference. Okay. So I would say that it is depending on the patients. It is not a general rule. And in general, especially growing patients get adapted to our appliances. There is an adaptation process. So you have a subset, a subgroup of patients that are the ones that are not getting adapted very easily. And this might happen even with aligners. There are also patients that are complaining of aligners. But for example, for patients with a huge burden of care, this is making the difference. Sometimes I have patients that have already, orthopedic treatments because they have orthopedic problems, and maybe glasses because, so other kind of medical therapy. And the orthodontic appliance, it is, increase the burden. So the parents ask if there is an alternative, and you try to offer the alternative. But I would say that it is not for every patient. And I would not say that for me, yes, I can compromise a bit on the result if, it is a syndromic patient and you cannot reach like perfection in that case. And maybe, for the patient is really important. But in general, especially with growing patients, I would not say that this quality of life point would make me think that I want to compromise on the result. I don't like this idea, to be honest. For adults, it is different.
I just want to touch up on the topic of growing patients that you've mentioned. Now, there seems to be a drive of a lot of companies to create products for younger growing patients. You've already mentioned that you're using perhaps other orthopedic appliances. You mentioned the twin block. Do you think this is an area where there is still growth in terms of aligners and developing their products so that they will be able to provide successful treatments to younger patients? Or do you think it's just commercial companies trying to find a new marketplace?
Okay, I do have cases treated with wings or twin block style aligners. So I do have also successful cases treated in this way, but most of the time they are not severe class 2 malocclusion, skeletal malocclusion with the huge mandibular retrusion. So I think still that bite jumping is better with rigid appliances, not with elastic appliances. So you have successful cases, but when you look to these cases, very often they are not really class 2 or with a very important skeletal retrusion. And there was a systematic review published in Progress in Orthodontics last June that was showing minimal effect on the mandible, even when you are selecting, the best papers with the best cases treated with these wings. And for sure, there is no possibility to have palatal expansion with aligners. And if you use alternative removable, the new version of expander made by aligner company, you have a lot of dental effects, so a lot of side effects with these appliances. So still classic Hyrax or Haas appliances are it is funny because when you place an IRAX, you get 50% of dental movements and 50% of skeletal effect. Only 50% of skeletal effect. How could you have skeletal effect with an aligner? I mean, this is really not reasonable.
Yeah. And it's great you relate it back to the material, right? And it's elastic material, and therefore, how can it create those orthopedic forces
Yeah,
and the
I'm sorry,
moments?
this is my background, so maybe I'm a bit biased on this side.
Well, by the virtue of your scientific prowess, right? And I think that's a great bias to carry. Um, okay, so you're an academic, and I've got to ask you the question. The statements come about so frequently in terms of the outcomes of aligner research that the research is weak, there's not enough studies, and we're 2.5 decades into clear aligners in terms of being a commercial product now. So what is it that's withholding this high quality research? Is it just the commercial cost of these things, and actually, it's difficult for research institutions to manage it? Is there are we discouraged from being able to do clear aligner therapy in terms of the university settings and academia? What is it that's stopping us getting the actual high quality answers?
So I will tell you a story. I have started my academic career doing research on materials, and especially in tissue engineering field, so interaction between stem cells and biomaterials. And then when I became an orthodontist, I needed, to do also some clinical research. I started with class 2 treatments, and this was my second PhD. And then I started also with aligners. And one day I was with Anne-Marie Jackman, that I consider the best professor of orthodontics we have ever had in the world. She's still very active, even if she's retired. She's, for me, she's the prototype of the best professor. And I was dining with her, and she asked me, "What is your research topic?" And I told her, I'm doing research on aligners. I just started some projects on aligners. This was like maybe 15 years ago or 12 years ago. She didn't reply, but she looked at me a bit shocked. Like, are you serious? Is this like a serious research topic? Because maybe 15 years ago, this was the feeling we were having regarding aligners. Then we have started on Masocastro we have started many projects. Most of them were retrospective studies. And of course, now we need randomized clinical trial, and this might be difficult to carry out them. We have started some of them, but it will take time. And once we have the results, on average, it takes like 7 years to have the results from a randomized clinical trial. The protocol that you will have used will be already old.
Yeah.
So you see, it is a never-ending story.
Okay. So there we have it. Vincenzo, thank you so much. It's been a real pleasure talking to you, getting your insights and some of those frank statements that you've given. Thank you so much for your time. Um, I want to ask you a question which we leave all of our guests to answer at the end, which is what one piece of advice would you give to the orthodontists who are listening to this podcast?
This is, I think, very difficult question because, to be honest, I am kind of very pessimistic about the future of orthodontics. So, if I have to give a piece of advice to my students or to the colleagues, I think that it is we need to fight for our profession. So that's so we should not feel impotent to change things, and we have really this duty to stand to fight for our profession.
What are we fighting against?
We are fighting against the idea that we are not anymore relevant, and that since it is only cosmetic, this can be done by whoever, and that technology can be used instead of human beings. So technology will replace, the orthodontist and this orthodontic knowledge. We have discussed it in the previous podcast, and the impact of artificial intelligence. My good friend Jean-Marc Retrouvé is working a lot on this, and because your best. So we have to fight this, but this is more general, because our life, not only our orthodontic life, our professional life, but our life is a bit in trouble for this, digital revolution, now the artificial intelligence revolution. So I think we have really to stand and to defend our profession.
Amazing. Vincenzo D'Antò, thank you so much for joining me on Orthodontics in Interview podcast.
Thank you. Thank you for the invitation.